over today, so that'll be a good one,
Yeah,
and then
this one.
you can decide the order.
Well, we can talk about, we can swing, we can talk about maybe the Ascension side first, right?
That's
Uh,
fine.
yeah, let's get
However you
right
want to do
into
it.
it. Yeah, good morning, good afternoon, everyone. Welcome to today's webinar session. Today's topic of discussion is going to be leadership under fire, managing through healthcare's most dangerous year yet. I thought that title would be pretty fitting, just considering everything that's that's been happening lately with the cybersecurity attack on Ascension, and now we got this Department of Justice $14.6 billion healthcare fraud sweep and all these things.
Yeah,
So,
yeah. There's quite a few things going on, right? Like
oh yeah,
I mean, all aspects of healthcare. If you're in management or if you're in owning a practice, you've got to keep your running shoes on. Things are getting a little bit hectic, but if you understand that within the chaos, there's opportunities there. Don't panic. You can come out ahead on this. I
no,
firmly believe that,
no,
anyways.
absolutely, absolutely. And again, for those that are joining for the first time, my name is Ray Walters. I'm with Epi Compliance and will be your host for today's session. I'm also joined here by my co-host and healthcare expert, Mr. Jose Delgado, 20 plus years of experience in healthcare consulting. Also currently owns and operates a mental telehealth practice. So always great to have him on here to give his insights. And I guess, Jose, to set the stage, um,
Yeah.
as far as, from your perspective, what do you think makes 2025 so dangerous for healthcare leaders?
So there's a lot of things in the marketplace that we need to assess, right? If we look at the external factors of the payers that we have, are they paying us for the services that we're rendering? Quite simply, because there's a lot of issues. And even how hard is it for me to get paid? How hard is it for me to get the patients through the door if I have to do prior auths? Which a lot of practices have to do prior auths for every bloody thing now. What is it? Is it simply an organic factor of getting the patients in the door, right? And then the internal factor of how do I manage burnout? How do I manage the providers? How do I manage the interrelationship between admin staff and clinical staff, and all of that fun stuff. Not to mention the compliance issues that are coming through, not to mention the fact that everybody wants more money, but nobody wants to pay more money. So then you end up in a chicken or egg situation, right? What are my value propositions for both patients and employees? How can I structure things so I can get more output with the same or less input, but that doesn't mean sacrificing our people, if that makes any sense. So it's finding efficiencies in the minutia. Uh, it's real interesting. It's been quite some time since I've seen an HHS appointee, a CMS appointee, an FDA appointee be so vocal and active in such a short period of time.
Sure.
Honestly, and we're not going to get political into it. We're just going to get into nuts and bolts about this stuff. But between that and the way that President Trump has moved, this is very similar. But even then, Obama and Kathleen Sebelius, the head of HHS, when the PPACA was passed, those were not on the same level of movement and assisting and looking to assist and looking to solve problems. So
Right.
it's this is all very interesting. If you're running the practice the same way you were 10 years ago, you have a problem. Quite simply, if you're running pre-COVID versus post-COVID, you've got a problem. You need to change it up. You need to at least look and review what your business practices are.
I think that's a good point, and I think that kind of just leads into the next, like I said, I want to touch on Ascension, but obviously compliance and cybersecurity sort of converging together. you know. Um, Need to have both, right? And we saw it in that Ascension breach.
Yep.
It started as a cybersecurity issue, became a HIPAA compliance issue, a patient safety issue, and obviously it affected their reputation quite a bit.
Yeah, well, their reputation and their bottom line, right?
Yeah,
Like,
yeah, absolutely. Because
so
they had what I think they couldn't even see patients, if I'm not mistaken.
no, they could
Their
not
whole
see
system was
patients
down.
in the every Ascension, and it was funny how it happened. It was interesting because it didn't shut down every Ascension location all over the entire org because there are 10 states, but all
Sure,
of the Ascension locations in Florida were
we're
shut down.
done. Yep.
And just that alone created a
So
$20 million operating loss difference.
it's a billing nightmare.
I mean,
And
it's a
everything,
nightmare at
everything.
every department level, right?
Yep,
Like
yep.
what am I doing with all of these patients? To how am I making money off of these patients? To the PR black eye. To the how do I? It's just a pain in the ass all the way
Absolutely.
through, all the way
Absolutely.
through. And remember that is also considering the fact that that $20 million loss is still there, even though Ascension sold a portion of their hospitals. All of the ones in, I want to say
Yeah, I
Alabama
think
to
it's
UAB,
yep,
and then there
yep.
are 9 hospitals in Illinois. So they sold out of 2 states and they still have a $20 million operating gap from this time last year to this time this year. So I mean, we highlight this just so that way we can be transparent with how some of these things can really affect a practice, not just on the immediacy, but on the short term to the midterm to the long term. If I'm a small to medium sized practice and I'm looking to sell, but I'm having to deal with a situation like this, or I'm walking in and I'm having to deal with the situation, the reverb
Right.
off of something like this, what are the ramifications of those situations?
Well, you're just
How
not,
much is that going to
in
affect?
that situation, you just got to know you're not dealing with just IT. You're dealing with data
Well, it
access.
always goes back to what was the breach point? Was
Right.
it IT or was it employees?
Right.
If it was the human element, then it goes back to training and HR. I hate to put it that way. You can have the most secure military base on the planet, but if they leave the back door unlocked, what are you going to do, right? So,
Exactly.
um, it's it it's nice. This case is nice because they're having to be transparent because of the nature of the business. I would love to see how it affected change there. I want to say the last time I saw was a forecast. They were expecting a $500 million to $1 billion lost. That's a whole nother
Oh man,
level a
that's a
another
lot of
level
money.
of mess. But that's an IT mess with the HR there. That
Sure.
one's a twofer. Whereas this Ascension one was 100% on the employee, based on what
Right.
was reported as the breach point.
Right.
What next? We had like 6 or 7 that we highlighted because I know we
Uh,
wanted to talk about the big beautiful bill a little bit,
we can dive into the big beautiful bill.
and then we can
Um,
go into some of the other
and then
stuff.
I know last webinar we sort of touched on the 14.6 billion healthcare fraud takedown.
Yeah, we can dive into that one next. So I want to split the big beautiful bill up into 3 basic sections. We're only going to be talking about the healthcare side, right? So if you are a practice that currently takes Medicaid, the big beautiful bill does impact you. How it impacts you is interesting though, right? Because for us as a practice, it doesn't necessarily affect us a lot on the front end. It affects us on the back end admin side. It affects us because of the patients, things of that nature, right? So if I'm a small outpatient practice and I take Medicaid patients for whatever bloody reason, then yes. Oh my gosh, the spending cuts. Okay, let's start with the spending cuts. It's $1 trillion over the next decade. I hate it when the government does this. They pass something and they say it's going to be X millions of dollars over the next decade.
Yeah.
Okay, so then realistically, it's $100 billion cut. It's not a $1 trillion cut. Cool. Okay. The most of those cuts are based on work requirements. So they're not actually cuts, they're expected cuts because they think the patients aren't going to do it, which some may not. That's on them. How important is Medicaid to them? That's something that I'm not going to touch on, right? Some eligibility requirements are going to be a little bit more strict in certain states. They're going to have a little bit more cost sharing. Welcome Medicaid to the private market because everybody every year that has a private insurance and Medicare, their cost sharing has gone up. Welcome. I'm not Nothing major here. If you're a rural hospital or if you fall under some rural contracts, there could be some negative impacts, but again, this is way too early for us to tell. Way too early. We'll have to keep an eye on it. We'll know more over the next 6 to 12 months, right? If we were to quote Pelosi, we gotta pass it before we see what's in it, right? Now, speaking of Pelosi and the PPACA, if you are currently on a heavy subsidized plan that is on the exchanges are losing their funding. You're losing a lot of the tax credits in regards to those products. Of course, because the subsidies are ending, the out-of-pocket costs are increasing. Now, this is seen as a negative, but there is a positive to this, and I'm going to go over that in a second. And then verification requirements, it's not just going to be. I equated this as the healthcare version of a ninja loan. You just had to say what you made. There was never any proof behind it. Oh, I only make $20,000. Okay, well, you qualify. Boom, you're there. Done. That's not you're gonna if you're gonna get subsidies, you're gonna have to prove why you deserve the subsidies. More paperwork. Welcome to the federal government. The one thing that I really liked about this is that HSAs are coming back to having the forefront that a lot of healthcare experts had wanted and pushed for and decried that the ACA killed off. Now, if you don't know what an HSA is, you probably know it as an HFA, a health savings account or a health flex account. Basically, what this account is a bank account that acts as a Roth IRA. However, instead of you being able to take it out to buy a house, you can withdraw whenever you need to pay for healthcare services. So the idea is that the HSA and the HFA allow for a lot more patient control in how their money is spent. So instead of paying a premium, to put a round small number to it, $100 a month with $1,000 deductible. And every year that $1,000 deductible resets, now you're paying $100 a month into an IRA, and that $1,000 deductible goes away.
Right.
Now you use this HSA, this HFA, if you haven't had it before, you basically get a debit card. And you just go and pay for all of your things with that. You can pay for over-the-counter drugs now. You can pay for services, obviously co-pays, things of that nature, medications. You know, if the healthcare provider takes credit card, you could pay with an HSA and HFA. That simple. This allows for now. They're creating that eligibility back. They're creating that flexibility back. The PPACA cut off HSAs and HFAs because traditionally at that time it wasn't just the Roth piece, it was also attached to a catastrophic insurance. So the argument against HSAs and HFAs were, well, what happens if you have a really bad car accident or you have a heart attack or you have a stroke or you get cancer? Perfect. Well, that's where you get a catastrophic plan with your HSA that kicks in at $10,000 in deductible but it covers everything above that because you're only kicking in for in case shit happens
Right.
for
Right.
those high ticket items. Perfect. Because my day to day expenses are cheap enough for us to afford. A lot of people just don't know how much these things should be. Your annual physical should not be that much money. It's an annual, not every month, not every 90 days. If you're one of those people that needs that, that's why you have Medicare. You know what I mean? Like, it's that simple, really. Most people do not need on that bell curve healthcare services once a month. And there's a good
Right.
reason to show that most people don't use their healthcare insurance once a month because of the fact that that's how the rates are. Insurance is based on a bell curve. All right. Remember this. Insurance, you want to know how insurances work. It's a very, very simple idea. 85% of the people on an insurance plan pay for the 15% that are high flyers. It does not matter what insurance it is. If it's life insurance, health insurance, car insurance, house insurance, renter's insurance, phone insurance, every insurance product is designed the same way. They are designed to where the majority pays for the minority. Okay. The reason why the PPACA got rid of the HSAs was because this way you created a larger pool of people that did not want to pay the tax penalty. So it was supposed to push healthier people into the market, into these products, and therefore artificially decrease the cost. That did not happen. I think it's been 15 years now, 16 years now. I
Yep.
think we can say that that was a major failure on that part. So we have to adjust it. Now, in because of these changes, the Medicaid side, the exchange side on the subsidies, and the HSA side, they're expecting that more people are going to be uninsured. 16 million by 2034. Okay. That doesn't mean 16 million tomorrow. What that does, though, is that it creates an opportunity for us as healthcare practitioners, as business owners, as business managers. Why? Well, because that means that there are more people that are going to have more money in their pocket. Because instead of paying for their copay, their deductible, and their health insurance, now they're going to need their healthcare services, and they're going to be a little bit more price sensitive, which means that you need to adjust based on your market. A Miami market is going to be completely different price scaling than a market in Northern Alabama. I can honestly tell you, you and I are in Northeast Florida, Ray,
Yep.
to get a tooth pulled because my uncle-in-law had to have this happen in Alabama. Over here in Northeast Florida, it would have been about $300-400. In Northern Alabama, where we were, it was $75. Completely different market, thus completely different pricing. What this does is it tells us
That's based off
we
population.
well, it's based on population. It's based on supply and demand,
Yeah.
but we also need to be aware of how much things cost. How much does it actually cost a practice for a provider to do their job, both in time and materials? I'll tell you right now, if you're doing an outpatient office visit, a 213, a 214, and they are not actually doing any tests right then and there, your cost is labor. Your cost is labor. If you're doing a basic 213, you're doing maybe a 214 if you're in a lower specialty or you're dealing with multiple issues in a primary care office. You're looking at a situation where realistically you're spending about 15-20 minutes with the patient. Shouldn't be more than $100. I'm going to be perfectly honest with you. Because if you put three of those together, you're at $300 in the hour.
Right.
Does that not cover your expenses? If the answer is yes, then hey, wait a minute, you now have a cash model. If the answer is no, my next question is why? Now, if we're talking cash, this is easy because I'm only paying for the credit card processor. But if I'm having to pay for billing plus the credit card processor because I got to get the copay on the front end, right? And then I'm going to get the patient responsibility on the back end 120 days later because we know that's how this goes. And then I'm paying billing to do the job in between, right? This is where you start getting all those costs that increase the cost of the visit. But if you could streamline all this stuff out, which honestly, this is what this is going to allow us to do, we can go for it. What is the value proposition? Healthcare needs to stop looking at this at people as they need healthcare, they're going to come to me. No, you're competing against every single person in your specialty in your geographic location.
Oh yeah.
So, what's your value proposition? What makes you different than the
Can tell you
thousand
right
other?
now, there's a dentist on every corner here in Jacksonville, it feels like.
Well, I mean, so
Very
we're in Florida.
saturated.
So, dentists and chiros and PTs, they're all over the place.
Oh yeah.
So, what makes you different? And of course, those three specialties have been dealing with a majority cash clientele for the last 16, 20, 100 years in the dental world, right?
Yep.
Most dentist practices have very, very small portion that has dental insurance. So honestly, the rest of healthcare needs to adjust. And you see that the hospitals are starting to adjust. And you see the Medicare Advantage companies are starting to adjust because they're starting to get concerned. So much so that the big insurance companies and the big insurance lobbying group, AHIP, Blue Cross, United Cigna, Humana, they all said that they're going to go and they promised to Congress and to Dr. Oz and RFK and President Trump that they're going to cut down or streamline the prior auth process, which could be very interesting for us. Some of them are saying, no, we'll do it same. We'll knock them out same day. We're going to reduce the amount of things that need prior auths. One of the things that was interesting to me is if you're switching insurances, you're not going to need to get a new prior auth for something you already got a prior auth for. I don't know how that one's going to work. I love the idea, but I don't know how that one's going to work. Uh, that would mean that they got everything that they had before from the prior insurance company in regards to medical records, which I don't know if they can do that fast. But I'm curious. We are curious to see what the final, how can I put this? The final effect will be. But honestly, all of these things are opportunities for us. If I'm a very medium to large size rural, which Ray and I were just talking to one of those 2 weeks ago,
Yeah.
the cut on Medicaid means that it allows for us, there's that money is going to flow. We just have to figure out who it's flowing to so we can create those conversations. Hey, maybe now I need to create a value add to make sure that those dollars come back to me in a different way. It's just changing the color of the money. If you're unfamiliar with the way government works, I'm going to do it in 2 seconds. When money is allocated to a certain place, it has to be spent by that certain place. That's why the budgets are so important because and everybody vies for more dollars every year. Even if you're in the government contracting, you know this. Right about now, for the next 60 days, they are trying to spend every dollar that they have left in their budget because if not, they cannot ask the federal government for the same amount or more because the federal government and Congress is going to say, hey, you didn't spend all your money last year. Why am I going to give you more money this year? Use the money from last year. Well, no government agency wants that. So they just dump money into stupid things. Ask any government contractor, they'll tell you this period of time, they're just signing contracts for all the stupid things they can to fill out the budget. So there's opportunity. Don't be black-pilled about it. Go for it. Look for what the opportunity is in your area. Every area is going to be different. With that said, we
I
can
was gonna
jump right into
say,
the 14.6 billion, which that is a wild,
I was gonna say,
wild
Jose, do
number.
you know anybody that's using any of the AI assisted prior auth tools?
So I know a couple of EHR companies are assisting their clients with some of those because the quicker the prior auth goes through, the quicker they get paid, right? Um, our practice uses it for Medicare patients,
Mhm.
honestly,
Has it been
it's
beneficial or
paperwork.
is it
Well, of course,
too much
I
input?
mean, it's paperwork.
Yeah, yeah.
You know what I mean? Like the AI can, oh, and this is where AIs can be useful, right? They can come in and say, especially if it's coming from the EHR or your billing company, they can say, hey, based on your specialty and based on what you're applying the prior auth for, they can kick back and say, no, it's going to get kicked back because the diagnosis code isn't meeting the need
Yeah.
for
Yeah.
the service. So then adjust this here or adjust that there, or you need to add this information from the record here so that way it will pop properly on the other side. Um, it's still very much just helping find the way. And as the insurance has changed their methodology, the AI will learn a little bit better. But the prior auth is just paperwork. It's just delay tactic or piss off the patient enough. And actually, I was just talking to a provider last week about this. The experience that they had, and this is a guy from a hospital. The prior auth was denied. So provider goes to the patient and says, "Hey, prior auth was denied. I'm sorry. If you want the service, you got to pay cash or call your insurance, and maybe you can push it that way." Patient calls the insurance. Insurance calls the provider. "Oh, why did we deny this? We didn't deny this. Oh, they didn't fill out the paperwork properly." And magically it went through. Then, no, it gets better. Then it goes back to, oh, well, if there's ever any issue, it's the doctor that signed that. So they're on the hook for something if it goes wrong. The same doctor was
Classic.
telling me about a patient that he said, no, this patient needs to stay in the hospital for 3 more days because if not, they have a high chance of
And
something negative happening to them. Insurance wouldn't let him, and they gave all the normal reasons. Doctor said, fine, I got to do what I got to do. Bye. And then, of course, patient came back 3 days later. Insurance company dinged the hospital for having the patient return back in under 30 days. And the doctor's like, how can you ding me for this when I did what you told me to do? And the insurance company said, oh, wait, but we didn't tell you. We didn't go to medical school. These are your notes. These are your orders.
messed
This is
up.
your signature. And I'm just sitting here like,
It's a dog eat
what are we
dog world right there.
What are we supposed to do with this? It's a no-win scenario. So don't
Yeah,
play.
yeah, can't
If it's a
exactly.
no-win, don't
As a,
play.
yeah, absolutely. You might
So
argue the
now,
doctor didn't, well, he put the trust in the insurance, that's just the
yeah, because at one point in time,
learn
it
lesson learned.
was supposed to be helping.
Lesson learned. Well, yeah, no, we can you want to dive into the Department of Justice? What was it?
Yeah,
324 defendants, 14.6 billion in
yeah.
alleged
So
fraud.
this one is interesting, right? This one was a multi-agency. Now, they termed this as an infusion center, but it was basically a giant office that was 324 defendants, almost 100 providers, nurse practitioners, doctors, pharmacists, etc., in
Right.
50 different federal districts and 12 state attorney generals. This stuff goes all the way back to COVID. This stuff is not just national but international, because the FBI even got involved because there was somehow the Russian mob was involved with this one.
Well,
Like
I
it
was
is,
looking, it says in the article the assets that were seized, it's like 245 million worth of cash, luxury cars, and crypto out
yeah.
of everything.
So
It's
they're
wild.
indicted on $894 million in fraudulent COVID testing and almost $300 million in claims payouts. So the
They called
COVID
it,
testing,
sorry, Jose, they called it Operation Gold Rush too. Sorry, I thought that was,
I'm sure when they
I
saw the
mean,
number
I mean,
attached to it,
it, the title's very
God,
fitting, very fitting.
yeah, right. So let's go over it, right? So how do you get to $900 million of fraudulent COVID testing? Well, I mean, how much was the COVID testing paying out during COVID? If you know, you know. than money in it. The money was there to
The money was
test
there. Yeah.
and test often. So it did not remember that the testing did not matter what the result was. It was just the COVID testing. Do with that conspiracy theory what you will. But if you had $900 million worth of COVID testing, that's a lot of tests. A lot of tests. And remember, this is where this is providers have to be careful because when these things occur, whether you know it or not, you're on the hook for it. This can 100%, the $293 million in claims payouts, we've got a problem in that those 300 million, the providers either knowingly or unknowingly were taking part. And it always happens the same way.
They were getting
Hey,
luxury cars kicked back to them.
I mean, but even before that, it's how you do it, right? Like
Right.
it's a matter of how does the federal government decide what that number is? And there's a couple of different ways that they do it. One, they play with the rules in respect of, hey, what is considered supervising versus not supervising? Hey, was this medically necessary or not? Did the patient even exist? Right? Or are you just signing notes? Because a lot of times we've seen this happen with fraud when it came to DMEs. The provider was just signing scripts for patients that they never saw, but they were trusting the DME admin, and the DME is sitting here just filing claims, and it was wild. Like if you're looking at the fake claims related to wound care, DME, telemedicine, COVID and genetic testing services, substance abuse services. All right. So let's go over the telemedicine one. The providers may have conducted the service, however, they may not have had an appropriate state license. Lots of fancy words to say if you have a Florida license, only see Florida patients. If you have a Georgia license, only see Georgia. Arizona, only see Arizona. If you have an Arizona license and you are conducting medical services outside of that jurisdiction, you're going to get in trouble. That's a false claim. Even though the service occurred, you have no right to be able to do that. So if you're a smaller practice and you're doing something similar, that's why you have to be very careful with verbiage and who you're billing. Very, very careful. So for example, if you're a therapist, and I'm going to use the mental health one because it's the easiest one, right? If a therapist has a Florida license, they can treat patients for that are in Florida. However, that therapist cannot provide therapy to patients where they don't have a license. That patient says they're in Colorado, all of a sudden they can't bill it as therapy. They can bill a patient and call it a consult. They can call it coaching, but you cannot bill the insurance and call it a therapy.
I thought you were
Same
servicing
service.
patients in Georgia there, Jose.
Huh?
I thought you were servicing patients in Georgia as well.
Don't play. Don't play. Don't play. So yeah, so I mean, this is really a situation where we've got to, if you're a provider and you're an employee or you're a contractor, you need to be very, very sure what you're signing off. If you're an older provider, if you're a provider of a certain age, back in the day, this was the same crap with the prescription pads. Your RN would come up to you and say, hey, all these patients need refills. You're in between patients, and you just sign off like 15 different scripts. And it was notorious that one or two of those was for the RN to pocket themselves. It's just the way the game worked. It was just the way that scam worked. Now, they cut down a lot on that in a lot of different ways. But with this, we're still seeing a lot of these fraud situations that are very, very basic in nature. You're not conducting the service, the patient doesn't exist, you're outside of the scope of practice or outside of the jurisdiction, or things are not matching up. You're asking for testing but it doesn't help you work with the patient in any way, shape, or form, which the genetic testing services is one that pings a lot for these.
Sure.
So, hey, I need a genetic test. Why? Patient has the flu. Who cares? Why are you getting a genetic test done? That doesn't make any sense. Now, if you're getting a genetic test done because you're dealing with substance abuse, which is what they're claiming here, then you're looking at, okay, what kind of drugs were they on? What kind of
Prior to,
drugs
yeah.
affect them in certain ways? That one you can play with a little bit more here, which is probably why they got to $14 billion in fraudulent claims. Now, keep in mind, too, when the federal government comes in to audit you, they don't look at every single record. They look at a sample. Okay. They'll say, hey, you're a small office, medium sized office. I want to see 50 records from this provider in this year, between this year and this year, right? That's usually how they'll do it. From there, what they will do is they will tally how many issues there were in those 50 claims and then extrapolate that out through the entire practice. So if you have a big office, if you have a multi-location, let's just say 12 location office, and you got one provider messing around, and that's the provider that gets audited, you on the admin side are going to have to prove, along with legal and billing, that that provider was an outlier. He was doing his own stuff out in the Wild West. That is not a representation of the practice as a whole. But the second they start finding stuff in multiple providers,
Multiple
now all of a sudden,
providers.
boom, I got you.
Yeah.
I'm going to get you for everything now. And then we're going to negotiate it down. And remember, all this stuff now, since the PPACA came out, this isn't just civil penalties, this is criminal penalties. All these providers just lost their licenses. No matter the result of the case, they lost their licenses. They're on the OIG blacklist. They can't work in healthcare. Even if they found a way to keep their license, they can't work in any situation that receives federal funding.
Terrible. I've read something too. It was what 106 defendants reached 35, or it was like 34.3 million in settlements already.
And you want to know, notice that the difference in the money that they claim was fraudulent
Civil
versus
settlements.
what they were able to recover is like 10%. And the reason is usually in this case, it's twofold. One, because a lot of people have already spent the money and it's gone. But this is also, this specific situation is also connected with it's international and it's connected with a group out of Russia. So they're not going to be able to track down those individuals or where that money went to because of
Well, CMS allegedly blocked an additional 4 billion in additional fraudulent claims.
million or billion.
Billion. 4 billion.
Billion would be, huh? So again, this is a situation where there's going to be a lot, especially with this charged atmosphere, there's going to be a lot of talks about what is waste and fraud, waste and fraud, waste and fraud. So cross your T's, dot your I's, make sure that you're doing everything on the up and up. If you're in the gray area, make sure you have a fancy letter from your lawyer saying advice to counsel. It will minimize, it will not decrease completely. It's not a get out of jail free card, but it will minimize your liability on something like this. Because you can say, I vetted this with a lawyer, the lawyer said this was allowable, and then let the lawyer argue the why.
Yeah.
Right? So we've got to be more intelligent about this stuff. We've got to be more aware. If this one is such a massive one, and of course it happened in our home state Florida for what
Go
was it, the
figure.
majority or like half of them were
Go
out of
figure.
Florida, and they were out of that certain part of Florida that always gets in trouble in healthcare, Miami. So if you're taking federal funding, if you're taking state funding, if you're taking insurance funding, you want to be very, very clear about what you're doing, whether you're allowed to do it. If you have any questions or concerns, find a professional, get with them, vet the process. Because just like I used with the therapy example 10 minutes ago, I can call it a therapy because my provider's in Florida, the patient's in Florida. But the second that patient is out of Florida, can't call it therapy. I can't bill it like therapy. I can call it coaching, I can call it consulting, but I cannot call it therapy based on telemedicine rules. If you are a DME practice or if you're a provider that's working with a DME company, be very careful with those kickback rules. Very, very careful. If you're receiving any gifts, in some states, if you're part of a pharmacy board, that's illegal now, right? So keep in mind what you're allowed to do and what you are not allowed to do. Be very, very clear. I do not say out of expediency purposes, don't bother reaching out to your state board. They never answer in a timely manner. But find yourself a subject matter expert attorney, and they will help you walk through it. There's no way they had a lawyer here that said this is perfectly legal.
No
No
chance.
shot.
No chance.
No
No, I think
shot.
the
So
attorney piece is definitely it's a must, right? And I would assume the attorney is going to be the one to tell you about any of the enforcement or rule changes. Um,
so having, and this goes back to what I've mentioned a couple of times, having that general counsel that's aware of what's going on and you're their client, they're going to pay attention to a little bit more of the stuff that's happening that would be appropriate to their clients, right? So they may not be a healthcare specific attorney, but if they have some healthcare clients, they're going to get a healthcare specific attorney that they can call and be like, hey, what about this? Hey, I've got this client. Do I need to be concerned about that? And lawyers talk to each other,
sure.
especially ones that are in different specialties. That general counsel attorney will also pay more attention just because of selfish reasons, right? They want to keep the client out of jail because if they keep you out of jail, you can keep spending money. That money can go in their pocket. So you have a situation where those lawyers are going to pay a little bit more attention. Hey, state board is talking about this with dental. Oh, my client's dental. Maybe I need to pay attention to this.
Right.
Oh, hey, this guy got picked up because he's a dentist. Okay, well, what did he do? You know what? And I'll call it right now. I'll tell you right now, dentists, especially pediatric dentists, if you are working with Medicaid or CHIP and you are strapping everybody down and you are gassing all the kids, you better have everything nice and buttoned up because that is a piece that will definitely kick you in the teeth because they'll call that as fraud and unnecessary. Why do you have a practice where every single patient needs to be strapped down, needs to be gassed out
Right. It
so you can do
it
your
should be
job?
offered as an option. Usually,
It so the
right? Depending
idea
on the circumstance, depending on
if you're
the
a dentist, you're only, especially a pediatric dentist, it makes sense to strap patients down
yeah,
if they're going to move around, right? But
exactly.
normally there's a process to this, not just automatic assumption that hey, every kid that comes in is getting strapped down and gassed.
That's a
That's
red flag.
crazy.
That's a red flag.
Yeah, exactly. Exactly. So you want to make sure that if that is something that you're doing, which is fine, you need to have it buttoned up as to why you're doing that with every single patient that comes in. I hope that all tracks. Uh, Now, the federal government's going to say that a lot of this stuff can be complex. The complex part is where the money goes and who's billing and who has the licenses.
Right.
Because it may be Acme Corp, the provider is an employee or has a separate practice, and then they have another practice at the pharmacy, another practice as the DME. They have one umbrella corp that owns the whole thing. Provider may be billing over here, or maybe they're billing under the entity name and not the provider name, which then causes a whole bunch of things as well. Remember, for Medicare, you want to go and have both set up as a provider. We want to make sure that we're using locum tenens properly because I'm sure that they also did something with that and caused some fake claims there or exaggerated claims there. So there's a couple different things. Keep in mind the federal government is using AI and analytics. They are tracking everything and they have been for the last almost 20 years. Every single claim that comes in gets scrubbed through those AIs that the federal government's been using since the PPACA got passed. The EHR's meaningful use was all designed so they could capture data so they could start enforcing. We are firmly in that enforcement. So, if anybody's got any questions, throw them in the chat. If not, you guys know how to get a hold of us for all that fun stuff.
Yeah, we'll take the
But
next minute or so. If anybody has any questions, please feel free to throw them in chat regarding today's session. If you have any questions about something else, hey, we're here to help. Um, yeah, just let us know. If anybody has any topics you'd like us to discuss, please throw that in the chat as well. We've covered some topics that some of our audience has mentioned in the past, and gladly do that again. Yeah, no problem, Kevin.
Kevin, we're here to
Kevin,
help.
if this is your first time joining, all of our episodes go on our YouTube channel. We're currently on Spotify and Apple. Currently working on getting that caught up. We've been doing these sessions since October 2023, so a lot of episodes that we've done. So,
Yeah.
our YouTube's the most current. I'll put our YouTube channel in here if you want to check out some other videos. We've covered quite a bit of topics. We talked about I know we've done some episodes when the Ascension cyber attack first happened, Jose. Obviously, we covered the Change Healthcare attack as well. Couple different situations.
If your primary care, also keep in mind if you're doing infusions or injections, keep in mind the supervisionary requirements. If you have mid levels, what are the supervisionary requirements for your specific jurisdiction? Because again, fraudulent claims does not necessarily mean that doesn't mean that the service did not exist or did not happen. It just means that it may not have happened in a proper manner, which means that it's wrong, which means that you owe the federal government money, right? So, one thing that we saw quite a bit was, hey, let's say that because stem cells is still an persona non grata, let's go with B12 injections. Okay, cool. And RN can do B12 injections in the state of Florida. Provider has to be on site. Okay. If the provider's not on site, then RN can't do it, right? It's that simple. But if the RN does it and you bill for it, then you have a problem. So you need to be very, very clear on your SOPs. What is on-site supervision? What is direct supervision? What is indirect supervision? These things, all of these things matter very, very much. Fraudulent claim could be something as simple as we are claiming that we're doing incident two. Incident two is a very popular thing. And if you don't know what that means, it means I'm billing at the higher doctor rate for a mid level to do the service. But what does incident two mean? It means that the mid level is not making any medical decisions. They're not changing the protocol that the doctor put in place at the time of the evaluation. They're just, okay, it's a quick follow-up. Oh, you need your meds because it's been 90 days. Boom. Here's your script. Have a good one. Then you can bill incident two. But if you change anything, you can't bill incident two anymore.
Have we covered that, Jose? That might be a good
We
webinar
have,
topic.
we have,
Or no, we
but fraudulent claims, a
we
lot of people get in trouble with the fraudulent claims. It doesn't mean the service didn't happen. It just means that you tried to upcode or somebody played a little game and that
got burned.
caused an overpayment and thereby causes
I'm
liability
trying to
on you.
remember what was the group that we did we cover I can't remember if we covered a organization that
There was
there's
a
a
couple of
bunch.
them.
Yeah, there's a
Yeah, there was a
bunch.
couple of them. So you want to make sure that these are the kinds of things that you keep in mind. All right. So I know that this is a little bit more on the billing side, but just that way you guys kind of have a little bit of a heads up. If you've been around the block for a little bit, the incident two rules haven't changed much. Telemedicine made it a little bit funky for a hot minute, but Same rules. Same rules. Now, again, incidence two means you can bill at the higher rate. If you don't bill at the higher rate, then you got to bill at the mid-level rate. The mid-level rate is 85%. And then if you're not following macro or MIPS or you're in the negative 9%, now you got to go from 85 to 74 or 76. So now instead of that 213 paying you $88 with Medicare, now you're getting paid $50, a little bit more
Right.
than $55. You know what I mean? So these are the things that if you're tracking numbers, processes are very important. Very important. Um, Now again, if it's cash, service rendered, pay me, I and more practices are going that route because it's just not worth doing that algebra that I just did. And then you got to do it for
Too many
every single
moving
product,
parts.
every single insurance.
Yeah.
That's wild. No, no. In network, out of network, PPO, HMO, Medicare Advantage. No. It's getting too much, man. It's getting too much. And I think that people are finally catching on that it's getting too much for us, especially for the smaller practices. Um, but yeah, if you're gonna go and play in this atmosphere, keep in mind that right now I'm in the opinion that healthcare right now is in that late 80s, early 90s corporate raider structure that is just being brought in by private equity, being brought in by insurances buying out practices at exorbitant rates. Um, it's going to settle down. And when it settles down, when providers start getting burned by these kinds of relationships, which is already happening, you're going to revert to seeing that heyday of mid 90s, early 2000s, where a lot of providers were splitting off from the hospital, splitting off from these larger practices and starting their own small practices again. Everything is cyclical. This isn't new. If you've been around 20 years, you know what's going to happen next. You know how this is going to go. So just figure out where you want to be and plan for it accordingly. If you're in a practice that's owned by providers, you can't come up with the idea on your own. You got to let them come up with the idea. So you got to set the map up so they walk into that idea that you're wanting them to do.
Star map it in
So,
advance.
yeah, yeah. So
Uh,
if you've got any questions, concerns, that's what we're here for. All right. What are we talking about next week, Ray?
yeah, so we got an interview next week with Dr. Delgado. And if you recall, we kind of left off. We talked about the HIPAA security rule changes in
Yep.
2025. So he's got some new material. He hasn't sent me the article yet, but I know he's working on one. But there's some things he wants to touch on regarding encryption, multi-factor authentication. Um, yeah, there's some
I'm gonna be honest with you guys on this one. I'm very curious to see how the
risk analysis.
industry is going to adjust with
Yeah.
some of these requirements because I just don't see it happening for certain things. If you have practices right now that aren't complying with what's out, being more strict and adding more rules is not going to be a good way to go move forward. So,
And
we'll
we're
see.
getting closer to September too, right? That's
Yeah.
essentially
I
when
mean,
things
all the
get
court cases
finalized.
are wrapped up. All the rulings should be, if they're not out, they're coming out, so that means that then we have the final rules and then the different agencies are going to say how they're going to enforce those rules.
The stage is setting.
Yes.
So,
Yes. It's now we can read tea leaves.
yeah. Nah, I'm looking forward to getting his updates and yeah, this should be a good one. But yeah, everybody that attended this, you'll get an email that goes out tomorrow that'll have the registration link to register for that event. It will be the same time next Tuesday. Um, Jose, I appreciate your time as always. I thought this was a great
It's
session.
been fun.
Shed a lot of good light of what's going on. Things are definitely getting interesting, and look forward to having you on next week. Everyone, appreciate you taking the time as well, whether it was your lunch break, maybe it's still morning where you're at. You just had breakfast. I appreciate you taking the time to tune in. Hope you found this session valuable. And well, we hope to see everybody on next week's session.
Absolutely. See you guys next week.
Awesome. Thanks, Jose. Take care.
Bye.